they subsidizing even a deeper gap to those that don't have? To my point about this question is we didn't measure Fort Worth as a whole. We measured it distinctly with 7 different subregions. Those subregions are not created equal, so it's not like you take the population divided by 7, but you're looking for some commonalities and some natural coalition of population that share the needs. What we learned, and again, third-party validated by Gallup, was that baselines for all of those indicated that over a 5-year period, the greatest gains in well-being, as measured through this process consistently by Gallup, were the people that had the lowest well-being to begin with. And again, we're not taking an aim with one type of solution fits all. The more that you can break this down, the better. In fact, what we've been asked to do is not just blue zone municipalities or neighborhoods, but now blue zone certified organizations, micro communities, because you run into different types of opportunities and different levers that can be used in those settings.
Well, I just want to add to that real fast because that is a concern, but at the same time too, like, my boyfriend is a store director at a blue zone in Lake Acres in
Microphone, please.
I'm sorry, we're something happy to a blue zone market, and then what you see is people from the outside community, from Hawthorne, Gardena, those people that can't afford to go somewhere, they can go to those blue zones. People that know about blue zones, they do go there. So, yeah, if you want to ask a question, I'm sorry, possibly over here, but they do use it. So, once it.
Thank you. To your point, that project is in its 8th year, and there's currently 197 blue zone restaurants in this.
My boyfriend has to have a blue zone. I'm like, oh, little.
I just have a question on sustainability, particularly in a community in Minnesota.
Yeah.
How do they sustain that fresh food, gardens, and walking in your winters?
Yeah. So the same way that people in Florida, Texas, Southern California do it in the summertime. We have programming, or in Texas where it's 120 degrees, or Florida where it's really hot. We do our programming, so how we engage people, for instance, in the summertime we do walking flies that are being launched at a community level and at a employer level. But then when it gets colder or in the places where it's hot, we'll launch purpose workshops or healthy eating or healthy cooking demonstrations or potluck wise. So it's a programming issue, but as it relates to sustainability, each of these projects have about 100 to 200 volunteers that sit on the committee. They're doing systematic blueprints every year with policy experts, their policy experts, continuing to lay out objectives, strategies, activities, and measurement on all the body of work that's being done, and to continue to hold the Blue Zone brand. It's about continuing that work and continuing that expansion.
So one more question from Neil Kohatsu, then we're going to transition to Susan Ivey. We're going to get back to this Q&A, but we do want to have a section that is about understanding this place a little bit better. So Dr. Kohatsu, one of our longtime steering committee leaders and a leader in cardiovascular health in California for a long time.
Thanks so much. I look forward to more discussion. But you alluded to the changing nature of faith-based communities. Maybe in the 50s it was traditional going to church, but I know at least the Protestant and Catholic membership church attendance is steadily declining. So what does faith-based community mean in 2019? Maybe in fact, what would that mean?
I don't have an idea at all, of course, but I would have an idea of how we learn that faith-based communities are a great place to engage people, affluent people, all the way down to the most challenged people. So we look at faith-based communities as partners in putting on healthy eating, healthy cooking demonstrations, hosting purpose workshops, putting out the message that it's okay to discover and go out and learn of other faiths, and getting people to get engaged. So when we looked at the 263 centenarians that we talked to, the 5 places where people live along these lives, the reality was that only 3 of them did not belong to a faith-based community. 3. So when you look at the longest people that are living the longest lives, one of those commonalities are that sense of faith. So our message is that: find faith, explore faith, volunteer, grow and strengthen communities. So thank you very much. We'll be around. We're happy to answer questions on the docs.
And we're going to keep teaming up. So, can everybody hear? Is that on? Betsy was running in and out a little bit, so if that happens, if our hand up and, we'll do this. We've heard from our Blue Zone experts, Tony and Ben, and, part of me just wanted to say what they said, right? But the 2 things that they said that I think are, so important are that, a lot of this is about behavior change, they call it lifestyle, and a lot of it is about changing our environments, the structural changes. These are things that are malleable, even though sometimes we think it's really hard and we're not sure we can do it. But we want to look at Sacramento today and sort of tee up their data, look at their hotspot data, and see if we can have some conversation about how we might transition Sacramento from a hotspot or red spot to a blue spot. So looking at Sacramento's data, we know we have higher mortality rates for coronary heart disease, for stroke, and for diabetes. And if we compare Sacramento to the other right care communities, we can see that in a lot of cases, Sacramento is doing no better than, and in most cases worse than, the state rate, and this is for coronary heart disease, worse than all the other right care counties except for Los Angeles. Similarly, for stroke, Sacramento's the 47th county, so worse than the state rate. It's the only one of the UVP communities that's doing this poorly. And we look at diabetes mortality, and again, in 51st place, Sacramento's not doing well. And some people would say, well, maybe it's just the demographics, but we can look at the age distribution, and actually Sacramento's a little bit younger than the rest of the state. And we talk about differences in conditions by ethnicity and race, but Sacramento is actually a little wider than the rest of the state, a little bit higher population of African American, but a little bit lower population of Hispanic, and a little bit higher population of API. So again, not a clear picture from the demographics why this might be. So let's look at risk factors. We have a great survey in the state, California Health Interview Survey. They look at 55,000 households over a 2-year period, and they do it over and over and over again. So this is average data from 2014 to 2018. Here's Sacramento in the red again. Doing worse on hypertension, doing worse on obesity, doing worse on smoking, resulting in higher rates of diabetes and heart disease, and higher rates of acute MI hospitalization. So one of the things that Tony and Ben talk about is sort of looking at the geography. This isn't a uniform system. You can't come in like they said Fort Worth, they had to parse it into places. But we can look at that Sacramento map and see that there's 15 zip codes that have the greatest socioeconomic inequity, and those also have the highest rates of disease and mortality. And from our little maps, you can see whether I look at diabetes, I look at heart disease deaths, I look at hypertension, I look at stroke. Those same communities in dark red and dark blue keep popping up over and over. So you look on the map, that sort of west side of Sacramento, a little bit on the north side, and those keep popping up regardless of the condition. So when you drill down into the census data here, it's not as easy as the answers that we wish we would get, right? So that top sort of blue spot for hypertension and red spot for stroke, it's actually an area of the, if you'll get census data, older community. Whereas on the west side here, we have a much more racially diverse community. So we're going to look at all of those types of things in order to figure out the solutions for Sacramento. And the things that they've said are the things we need to do. How do we get lifestyle change around our community? How do we get structural change for justice in our community? And we're going to have some discussion about that. We have 4, I think, people from Sacramento who are going to go over some of the issues that they've worked on and how they've come up with some solutions. And who's next?
Dr. Romer, our chairman of the Sacramento crew. Thank you.
I'm going to leave the triangle out here. And Jessica, I just want to say while he's teeing up, not just high blood pressure, but also physical activity for Alzheimer's change. So,
No social isolation.
That's a strategy to address blood pressure though, too.
Yes.
Right? So sometimes it's important to have one thing and then everything that goes with it. Diet, exercise.
And
Right, right.
So thank you very much. We all realize that Sacramento and Northern California is a hotspot for cardiovascular disease with a high incidence of it, and we know it by county. In California, we know it by zip code in California. And one of the things Neil brought up earlier is how can we really, track this, because instead of looking at measurements, which are often data harvested in a healthcare system, submitted, where can we look the next step, which is really outcomes? Because in the end, we all want to improve those outcomes. The high incidence of strokes and heart disease is what we want to come down with. We do have that ability in certainly Sacramento to do it by looking at both stroke rates, mortality rates, etc. We have the ability in some situations, certainly for individuals who have procedures, to actually risk adjust it with a number of risk parameters through the Office of State Healthcare Planning and Development. And so we can provide those outcomes for it. So I do think we have that ability. We have a motivation. We have in Sacramento a relatively motivated healthcare provider and healthcare program that's available. We have a governor's office that, as Fig has mentioned before, our Gavin Newsom wants to be known as the healthcare governor, and wants to make that the legacy for his governorship. We have a motivated Senate and Assembly. We work closely with the head of the healthcare committee for both the Assembly and the Senate in California. They're motivated individuals who want to provide better healthcare. We have in Sacramento City a motivated mayor who is clearly interested in improving healthcare and individuals and improving on diversity for that. So we have all of the components in place. We have organized healthcare systems and providers that are there ready to move. We've talked to each of the leaders of the healthcare providers in the Sacramento area, and they're motivated and interested in this. And I actually have emails from them saying that they're 100% behind this at this point in time. And we have the California Department of Public Health, which is here today, and certainly strongly supportive of that. So we have the support, we have the problem, we have the possibility of fixing it, and we have done a lot with what we have, but going the next step, and the next step is into the community. And into the community, I've been to a number of these blue zone areas, and it hits you when you walk into the clinic, when you walk into the supermarket, when you walk on the streets or sidewalks of that community, you see right away the influence of it at that point in time. So we see that, we can measure it, we've got everything all assembled. There is an elephant in the back of the room, and that elephant in the back of the room is, I clearly see that improving healthcare and reducing morbidity and mortality will be cost effective. Not only that, it will be cost savings at that time. So we will save money for that. But for the 40 individuals in Texas who were required short-term to train everyone and do that, my real question from Blue Zone is, what's the short-term financing of this? Who pays for those people to come in? Who has, in those communities, ponied up to put in the money to provide the funding to get this underway? Because I'm pretty sure that Blue Zone's not going to just move in here without having some assessment of the pay for. And the pay for performance is too early at this time. We will need to have short-term funding so that we can get it before we can talk about pay for performance for that. So the question would be, is healthcare providers going to step up? Are insurance carriers going to consider stepping up at this point? Do we tap into the government and realizing that all of these entities are financially stressed at this point in time, and there's not a lot of money on the table for us to just go up there and pull out at this time? So in reviewing the program, I think we've got a great direction. We can do it. We've got the capability. I think we have to look at the final step, which is who pays for the next couple of years of getting this program underway. And if you'd love to answer, we have to do that.
We could share with you, Tony shared with you 52 different communities and projects. They've all been funded through private sector. So the public sector's participation is critical. So whether it was mayors or a county commission or whether it was governors at the state level, all those different entities have budgets that already exist, and experts can be partnered with those organizations in order to think about how to re-engineer certain amounts of those budgets to aim toward impact of the Power 9. But the team that you were referencing, the 40 people on the ground for a 5-year period in Fort Worth, were supported through the private sector. Their work and the work around them and bringing in experts in different areas were funded by a coalition of large not-for-profit health systems, a regional blues plan, and a foundation, as well as multiple large employers in the area. So when you think about the effect that has been achieved, lower medical costs, who's going to get to capture the benefit of that? And it ranges from citizens in some degree, but largely payers, whether those be large self-insured employers or whether it be health insurers. Improved workforce performance is going to go to the employers. And if you can get productivity, direct productivity, measurable change, we know that that lends itself to better economic vitality for the region in measures like direct and indirect household consumption. So we saw those outcomes, and so the private sector leaders have been health foundations, health systems, and health insurers with complementary coalition of the largest employers in those regions that pool together to fund into these initiatives.
And Ben just laid out very well, I think, that one strategy, and it's actually the same strategy I've been pushing around, very specific goal of hypertension control. You know, it's not going to happen, I'm sorry to say, by the federal government. or the federal budget, even the budgeting process, where you have to, everything is on a one-year cycle, it doesn't work. And you have to have people with a longer range plan. But having said that, I want to make sure, I wanted to say this before I left today, at some point this seems like a perfect time. For those of you who haven't seen it, the Office of the Assistant Secretary for Health recently put out a request for information called Prevention X. I don't know where this is going, I'm being very honest with you. I don't know what's going to happen with it. But it's the first time, to my knowledge, ever that we have recognized as a department the importance of prevention and the fact that we aren't doing what we need to make the gains that are necessary. So, they want novel interventions for non-communicable disease. It's open now, it's open until December 13th. Give them some great ideas, and I mean, this is one of them, right? So, like I say, I don't know what's going to happen with it, but I know if you don't put things in, it won't be there. So I would encourage all of you to take a look at it. Just Google Prevention X, and let's give it a try.
And just to one point that you made in follow-up to that was, what's the horizon for return on the kind of investment that would have to go into something like this? So across our projects, typically around the 3 to 4 year mark of the work toward transformation, you cumulatively will pay back the investment. So that's kind of the break-even time frame. So it's a different, if you go to private sector, you talk to a CFO, they want you to break even in 9 months and begin to get, a 2 times return or greater in a 2 year period, kind of as fundamental. These have a compounding effect because it's a different kind of value model. And you really have to remember that, because the changes that are being made are often generational in nature. We just got done doing an exploratory and feasibility analysis for a portion of a state. And in the audience was a fellow of one of the foundations, very prominent foundation that was considering measurement. And I recognize the individual as someone who has spent the last 30 years in looking at the measurement of these kind of models in a research-based area. And we got done talking, his hand went up, and I thought, oh boy, here it comes. And he says, I only have one comment with the analysis that you guys did and the projections that you're sharing, is they're all understated. And it's largely because the fidelity of our modeling on a research level is really hard to get out with high confidence intervals around simulation forecasts past a decade. In fact, many in this room probably would criticize even that's too far out. But he said the changes and the impact that you've made in places like Fort Worth on single risk factors, things like smoking rates, have generational lifetime value that extends to a degree by which you would look at the ROIs that would be 30, 40, 50 times the initial investment for change. And most financial people and researchers might look at that and say, oh, that's the proverbial hockey stick and those will never happen. He was saying you're underestimating the value impact of what's being done. So we typically would see somewhere between 5 to 10 times return in a 10-year period off of a 3 to 5 year transformation. And that even after you've made the changes, there's always a question of sustainability. The amount of energy to sustainability and resource intensity isn't the same once you make the transformational changes. And so what happens is the generational impact continues to compound the value at higher rates while the amount of resource necessary to kind of keep work going trails off. And so the returns on the investment expand further out in time. So I just want to make sure everybody understands that these are not traditional models of individual diagnosed, treatment effect put in place, and as long as the treatment therapy is in place, you get an effect and a return. But the minute you take the stimulus away, or the reason why you get compliance with a particular therapy, we know what happens with recidivism to the ROIs. The beautiful thing about making semi-permanent and permanent changes to the environment that presents a different choice architecture for people as they navigate and live their life, is that a lot of it is unconscious and going to be sustained without the traditional intensity of costs over time that you would normally see in an individual expert model. So really important to note, this is a different model. And a lot of the things that I learned was taught in school, that what we're learning become kind of inconvenient truths to a lot of what we've assumed is the truth, kind of solely through the way in which we've done things in the past.
So perhaps we can sit down with you or your group and look at actual numbers on return on investment and the legacy of that too, because
Yes.
that will be important. Remembering that Sacramento has approved a basketball arena, looking at big investments. We're about to approve a soccer stadium as well with huge numbers in there. So Sacramento, we do have the wherewithal to dig up big pockets when we need for that. And it would be very helpful to make sure future plans for Sacramento do include something along the lines of Blue Zone and how we facilitate
It's
that.
interesting because we just launched 2 what we call kind of exploratory work streams. One in Orange County in Florida, in Central Florida, which is about 1.5 million people, and then the Tri-County area in Austin, which is approaching 2 million people. So similar type size places. And to your point, the elephant always in the room is not whether or not this makes good sense to pursue or that this model can't work. I think we've done it enough times to show that it can under the right circumstances. I think the real challenge becomes, where does this fit as a priority to even where there are a lot of resource still has to be chosen as a top initiative. Otherwise, it won't happen.
So Dr. Rebelo is here, and we'd like to ask him, as an independent Southern physician, do you feel your group is supportive of this and would be willing to, let's say, pony up to participate?
Before I answer that question, I think Catherine had a question.
Carolyn Peck.
Carolyn.
From the California Department of Public Health, and then we'll go to Dr. Rebelo.
Oh, thank you, Dr. Rebelo. No, I just had a comment to make. There is a group in Sacramento called Design Sacramento for Health. And we also have Walk Sacramento in Saba, which is a bicycle organization. They're very politically active, they like to make change. So I think there's a lot of community partners already here in the area that would buy into this with like we're doing. I'm really happy.
Thank you, sir. So, again, I'm José Rebelo. I'm a family physician. I'm the chief medical officer for Southern Independent Physicians. And Hattie wrote me and Parag to be the founding chairs of Sacramento Right Cares many years ago. And that was a great experience. One of the visions that we had about that was essentially this, that at some point we wanted to bring, the competitors together around improving the health of the community. And how can we work together for that very basis? Because we can share best practices and ideas, and that's the whole purpose of Right Care. There also was, by the way, at a time when we started, something called a Healthy Sacramento Coalition. And that was aimed at getting some funding from the federal government to do exactly some of this, not the whole thing. And there was a lot of activity, and I volunteered, although I did it, I think with some support, that we could become the clinical side, because we're the clinicians of the Healthy Sacramento Coalition, which is really a conglomeration of other organizations, many of which were not specifically health organizations, but had, because of what you just described, vested interests. And that was very exciting. The other piece that we like to bring into Right Care in Sacramento was the community of the FQHCs, the community clinics. And we reached out to the FQHCs at the time. We had an organization that no longer is active, that was the bringing together the community clinics, and that was very powerful. We also brought in our public health officer, I'm blanking on her name now, Olivia Caceres. We brought her in, that was very powerful. So we had